Professor Feras Bader. He's a clinical professor of medicine at Cleveland Clinic, and he is the vice chair of the Department of Cardiovascular Medicine and the director of Heart Failure and Transplant section at the Heart and Vascular Institute of Cleveland Clinic, Abu Dhabi, and he's also the chairman of the Emirates Heart Failure Working Group. Dr. Firas will present the pathophysiology of acute heart failure and the different profiles or characterization of these patients. Dear Firas, the floor is yours.
Thank you very much, Hadi. Can you hear me well?
Yes.
Thank you very much. It is a pleasure to join you again in one of your educational series, and I would like to thank you personally for your efforts during these virtual education times, and also thank the Lebanese Society of Cardiology for their support of these educational activities. My task today was to start with discussing pathophysiology of heart failure as well as characterization. And I will have to apologize in advance because there's no more interesting pathophysiology in this syndrome than the interaction between the heart and the kidney. And I try to stay as much as possible from discussing any decongestion strategies, knowing that Professor Mullins is going to be talking about this, and also try to stay away from the recommendations that I anticipated Hadi might be making in his presentation, and focus more on that interaction and some of the subtypes. So I will talk about some concepts, including this interesting dialogue between the heart and the kidney, clinical approach and phenotypes, and share with you a little bit on our experience in managing acute decompensated heart failure admissions. This is a well-known figure to most of you. It talks about the three-phase terrain of lifetime readmission risk after heart failure. Usually the earlier transition phase is the phase where the admission is relatively new and patients are adjusting to their condition. And then there is the plateau phase where the risk of readmission is fairly low. And then, of course, as the disease progresses post-discharge, the risk of readmission becomes higher again. And that's when we start looking at this as a sign of progression of heart failure due to these recurrent admissions. As a matter of fact, it is well established that mortality increases progressively after each heart failure hospitalization, higher after the first admission, higher after the second, third, fourth, and so forth. So heart failure admissions beget heart failure admissions, and then with each of these admissions, the risk of mortality becomes higher. Now, traditionally, the pathophysiology discusses an insult that leads to cardiac dysfunction. That cardiac dysfunction leads to neurohormonal activation. Neurohormonal activation then leads to a series of changes that result in renal vasoconstriction as well as fluid retention, which increases preload, afterload, and further compromises the cardiac performance. And then this becomes a vicious cycle between symptoms worsening as well as neurohormonal activations increasing as well as cardiac dysfunction advancing. Now, I will stimulate your thinking by introducing this concept of potentially non-traditional pathophysiology or fluid shifts. And as we talk about subtypes, we will be talking a lot about congestion, and it will remain the backbone of heart failure decompensation. Decongestion will be the backbone of heart failure management in the acute setting. But there is this interesting physiology where you might not actually start with a cardiac insult necessarily, but you might end up with this neurohormonal activation before you induce it through the cardiac dysfunction. And then the neurohormonal activation or the increase in preload and afterload in and by itself then stimulates that cycle from that point, rather than always start with cardiac dysfunction as the entry point into this cycle. This is a fascinating paper that I really like. It talks about future device concepts in the management of acute heart failure. And it summarizes pathophysiology very well. So again, decreased cardiac output leading to increased sympathetic nervous activity, increased renin-angiotensin aldosterone system, non-osmolar vasopressin increase, and then you end up with decreased renal artery pressure, decreased vascular resistance, increased venous pressure at the level of the kidneys, increased vascular capsule pressure. All of this leads to decreased blood flow to the kidneys, and as a result, decreased filtration of sodium and fluids, which means increase in filling pressures, and then the cycle continues. Now, if you look at why patients become resistant to diuretics over time, it's more or less an aggravation of these neurohormonal mechanisms. But it's it's multifactorial. So as we treat people with diuretics, we should get rid of the fluids. But over time, people become less and less responsive to diuretics as their disease progresses. And that could be because of reduced absorption at the level of the GI tract, inability to bind to albumin as far as the drug is concerned, reduced filtration due to reduced renal blood flow. And for those who did not know, loop diuretics, as a matter of fact, require adequate blood flow to the kidneys for them to work reasonably well. And as we will discuss throughout the course of the evening here, one of the things that you can overcome diuretic resistance with, as you'll hear more in the course of the activity, is to improve renal blood flow if that's the reason for the decreased response to diuretic therapy. And of course, there are science to assist for that. So as we look at the heart failure from a pathophysiology standpoint, we have to kind of put this in perspective when it comes to managing heart failure patients. Patients come in decompensated, as you can see here to the left side of the screen in red. And then as they're admitted to the hospital, we're treating them to alleviate that decompensation, mostly by managing the congestion, which is mostly the culprit in their decompensation. And then while we're doing that, we need to continuously assess them by looking at their trajectory. So, they get better, and then we start planning for discharge, as you can see this blue phase here. And when we discharge them, it's an optimization phase to prevent readmission to the hospital again. Okay. And of course, with time, what ends up happening is that we are up titrating guideline-directed medical therapy and moving away from the hospital admission, hopefully without needing to come back to it again. So this trajectory check, as it came out in the consensus statement from the American College of Cardiology, is important because as patients go through these different phases, their requirements based on how their condition is are changing, and their assessments and medication needs are also changing. So we'll probably hear about this throughout. But whenever a patient comes in with acute decompensated heart failure, they have to be assessed to know whether they're congested or not congested, and whether they're perfusing adequately or not. So warm versus cold, refers to perfusion. Wet versus dry refers to congestion. And again, we'll come back to this concept of some patients actually decompensating, but do not really fall in the category of either dry or wet necessarily. And I'll come back to that. Again, a lot of interactions between the heart and the kidney, neurohormonal, hemodynamic, and as far as perfusion or congestion, renin-angiotensin aldosterone system, sympathetic nervous system. A lot of pathophysiology is taking place interchangeably between the heart and the kidney. As a matter of fact, when you look at the classification of cardiorenal syndromes, type 1 cardiorenal syndrome is specifically worsening renal function in the setting of acute decompensated heart failure. So what produces this from a pathophysiologic standpoint? worsening of kidney function in the setting of acute decompensated heart failure. And if we're talking about the pathophysiology of acute decompensated heart failure, we really can't separate that from the cardiorenal worsening that takes place during these decompensation episodes. And I just wanted to share with you a few studies in that regard. So this nice study looked at patients with different ranges of cardiac index, low to normal, and looked at some of the renal parameters that we use, like GFR, BUN to creatinine ratio, and creatinine. And interestingly, the differences in cardiac index does not really reflect or correlate well with the differences in these renal parameters. It was one of several studies that highlighted that it may not be simply the reduction in flow that is affecting the kidneys, but it's more complicated than that. This is a neat study that looked at intrarenal hemodynamic evaluations by Doppler ultrasonography and heart failure. And what I can share with you here, looking at these different venous flow patterns. Of course, moving from the left to the right, it's a worse venous flow pattern. If you look at things like the cardiac index, there was no difference in the cardiac index as far as the different venous flow patterns are concerned. But if you look at things like the pulmonary capillary wedge pressure from the left to the right, or the mean right atrial pressure, you can see progressive rises that is statistically significant to correlate with worsening venous flow patterns. So it seems that filling pressures actually impact kidney pressures internally at the level of, and reflect on venous flow a lot more than what the arterial flow does. As a matter of fact, looking at outcomes and cumulative event-free probability, it is indeed the right atrial pressure that is high with a discontinuous flow pattern that ended up with the worse outcomes. And similarly, event-free probability, looking at the systolic and diastolic hepatic vein flow, similarly, congestion here reflected really well on events long-term. But we knew from studies before that outcomes by congestion status and diuretic dose are actually well correlated together. So if this is from the Everest study that looked at tolvaptan, which was obviously a neutral study when it comes to managing acute decompensated heart failure. But if you look at the differences between high versus low dose, it's always worse when you have high diuretic dose compared to a low diuretic dose. But compare congested to not congested, and you can see that the outcomes are clearly worse when people leave the hospital with evidence of congestion. As a matter of fact, and this is an old paper, just clinical findings of congestion indicate worse outcomes, things like elevated venous pressure, as well as third heart sound. So my message so far in my presentation has been the pathophysiology of heart failure is dominantly revolving around congestion and dominantly revolving around cardiorenal dysfunction in particular. This will be alluded to during the course of the night, but we're not necessarily doing a great job with congestion, and we'll hear more about this as we move on. But congestion is so bad to where among the important reasons for keeping residual congestion and being unable to get rid of acute decompensated heart failure is advanced renal disease. So having worsening renal function in the setting of acute decompensated heart failure is almost inseparable. Now, as people get decongested, it's important to understand that worsening renal function in that setting is not necessarily a bad thing. This is just a confirmation of that pathophysiology. And as a matter of fact, people who end up with worsening renal failure but remain congested have the worst outcomes. people who end up with worsening renal function but no congestion do better than people who have congestion without worsening of renal function. So decongestion is really, really important, and we'll hear more about decongestion strategies. All of these are to just emphasize this concept of congestion as a foundation for acute decompensated heart failure. This was another interesting study that looked at the renal effects of the intensive volume removal in heart failure with patients with pre-existing worsening renal function, basically the Feras heart failure trial. And in that study that we all know that compared ultrafiltration to standard therapy in patients with worsening renal function, there was a sub-study of patients who had renal tubular injury biomarkers measured. So N-acetyl glucosaminidase, kidney injury molecule, and neutrophil galactinase associated lipocalin. These were the injury molecules measured in this subset of patients. And what I wanted to share with you again is that even though at the time of randomization, the differences in injury molecules was not significant, in any of the three, in patients with or without decline in kidney function. After the enrollment, patients who had worsening renal function had more injury, except that those patients actually ended up with more recovery at 60 days. So again, highlighting the concept that when you see worsening renal function in the setting of effective decongestion, it doesn't necessarily mean bad long-term outcomes. The reason I'm showing this is not to show you another slide of pathophysiology, but this talks about the importance of multidisciplinary team approach when it comes to acute heart failure with acute kidney injury. When these two are happening together and there are issues with management, the earlier involvement of multidisciplinary approach to it between cardiology and nephrology, the better it is for patient outcomes, because then you can assess your approaches and then decide whether they're effective or ineffective and implement other strategies for decongestion, as we will hear. Other considerations when it comes to impacting the kidney function in the setting of acute heart failure have to be kept in mind. Things like medications, contrast, and of course medications including not just cardiac medications but also non-cardiac medications. It's very important as you evaluate this collectively. And again, this is something that could be done better when you have a multidisciplinary approach. What about the theory of injury in the setting of acute heart failure? There was a proposal that the increase in cardiac stress could lead to myocardial injury as manifested by a rise in troponin, and this could lead to worsening outcomes for hospitalizations and increased long-term cardiovascular death. And the idea here was that ventricular distension during acute heart failure leads to myocardial injury, explaining why such episodes are followed by acceleration and downhill course, and was a rationale to consider vasodilator therapy to reduce congestion and ameliorate the cardiac wall stress, which potentially could result in reduced injury. However, as we looked at vasodilator studies specifically in the management of acute decompensated, looking at cardiovascular death with ularitide versus placebo, there was no significant difference. There was actually no significant difference in high sensitivity troponin as well. And of course, with the relax AHF with serelaxin, there was also no difference in cardiovascular mortality as well. This is a slide courtesy of my dear colleague Hadi. He always refers to hypertensive and normotensive and hypotensive acute heart failure. The reason I'm bringing this up is to just talk about this alternate pathophysiology. In hypertensive acute heart failure, the symptoms are usually abrupt, and it's more common in females, more commonly in heart failure with preserved ejection fraction, and it's commonly the first episode, or in people who have been mildly symptomatic or asymptomatic for a long time. It usually is a manifestation of a rise in filling pressures that actually results from redistribution of fluids rather than volume overload. And I'm sure you've all experienced in your practices patients who come in with pulmonary edema that you diurese, and then by next day, they're completely euvolemic. So I'm not sure where we put these patients. I mean, we can call them congested temporarily, but they're not really volume overloaded. So the term wet might not really apply to them very well. The term dry might not apply to them very well. So they fall somewhere between this category of dry and wet, and manifest this different pathophysiology of um, redistribution congestion rather than volume overload congestion. Hypotensive acute heart failure, on the other hand, is rare. It's less than 10% of cases. And what you need to look for here is signs of cardiogenic shock, basically altered mental status, low blood pressure, high heart rate, cold extremities, poor urine output. This is alarming because these patients need to be acted on very quickly with consideration of inotropes and perhaps mechanical circulatory support. Just briefly on the experience from Cleveland Clinic Abu Dhabi, we actually created our independent inpatient service for heart failure now for since beginning of 2017. So we had 4 years of this experience now, separate from cardiology even, and we created an algorithm to decide where patients go, whether they go to the heart failure service, whether they go to the general cardiology service, or they go to the hospital medicine service based on the reason for presentation primarily, as well as their background. But we did an initial survey to look at our patients, comparing those who were admitted before we established this service to those who were admitted after we established this service, just immediately the 90 admissions before we created it to the 90 admissions after we created it. Not much different in baseline characteristics as far as background and risk factors and medications before the heart failure service and then after the heart failure service. But what was remarkable is just by creating this service and looking immediately at the first 90 patients compared to the last 90 patients who were admitted with heart failure before the service was established, we changed readmission rate in an exponential fashion. We had a readmission rate almost in the 25 to 30% range that came down to less than 10%. Of course, our current readmission rate is somewhere in the 15% range, which is still less than North American centers, but it's something we try to keep down as much as we can. And of course, we reduce the mean length of stay, in addition to reducing things like ICU admissions as well as inotrope medication need. So in summary, type 1 cardiorenal syndrome complicates the management of acute decompensated heart failure and carries a significant morbidity and mortality. Multiple neurohormonal and hemodynamic pathways contribute to the development of it, as well as the pathophysiology of acute decompensated heart failure in general. Venous congestion, systemically and intrarenally, seems to be the major final common pathway in the pathophysiology of type 1 cardiorenal syndrome and acute decompensated heart failure. The management of acute decompensated heart failure, when complicated by worsening renal function, requires multidisciplinary approach and careful assessment with close follow-up. The key approach is to relieve congestion, sometimes even at the expense of mild renal dysfunction, and initiating therapies known to improve long-term outcomes. I hope this was a good summary of this pathophysiology. Again, I apologize in advance for stealing the thunder of my colleagues if I took some of the information that they were going to present on regarding congestion or decongestion or some advices in its management. Thank you.
Thank you, Firas. Thank you for this comprehensive, really, lecture or presentation